Hi everyone. Please subscribe to the channel if you've been enjoying it for these past few years. It really helps to keep the channel going. And do you know that 30% of my viewers are subscribed? That means 70% of you watch and you're not even subscribed. So go ahead and help this channel out and subscribe, please. All right. And share and like and ring the bell. All right. On to WAG Part 2. Hi everyone, I know that you all have been waiting to hear about the second video in the WAG series with Wendy Zander and I, and here it is. It's coming this weekend, so check it out. There's also some really great things in the description show notes, so make sure you check below. We've got info about the IsoGuard mask by Teleflex. There's also information about dosimeters for WAG from Assay Technology, and there's a 10% discount code, so check that out there if you want to purchase those dosimeters for your teams. And then also there's a link for the WAG playlist from PACU NursingMinutes. If you want to learn more, if you want to hear my interview with Dr. McLaughlin, or if you want to learn about one hospital's experience implementing a scavenging system, go ahead and check it out there. So lots of good stuff, and also links to Wendy Zander's company, Zander Perioperative Education. If you are an OR nurse looking to get certified, definitely check out her website. All right, everybody, I know you've been waiting for a long time. Thank you for your patience. And also, I wish the best of success to all the nurses who are testing for the CAPA and CPAN certification this fall. You're all in my thoughts, and please email me and let me know how you're doing. And we want to share your certification stories. So make sure you let me know how everything goes. All right, now back on to hearing part 2 of WAG from PACU NursingMinutes and Zander Perioperative.
I think we've talked about this before, but the ventilation in the recovery area, the requirement is that 6 air changes an hour and 2 with the outside air. And that is the same if you were in an office. You know what I mean? Anywhere in the hospital, any building, not specific to healthcare, is 6 air changes an hour and 2 with the outside air. That is just your HVAC at your house, okay? So that is not helping you. It's not helping you. Now, in the OR, there are a couple of different regulatory requirements for those air changes. Because if you look at NIOSH, they require 15 air changes an hour, 3 of those with the outside air. However, AORN and also Joint Commission require 20 air changes an hour, 4 with the outside air. And it just depends on whether your air handler can do that or not. The air handler for surgical services is a 6-figure pay, okay? I mean, that's really expensive upgrade. So the older air handlers cannot do 20 air changes an hour. So NIOSH has not changed their recommendation, not because it's not the best thing, but because they realize that it is a 6-figure bill to have those new air handlers put in. So I assume that one day the recommendation will increase. But right now, if NIOSH said 20, many hospitals would pay up. Newer hospitals or ones that have had renovations in the OR, nobody puts in a 15 air change an hour air handler. All of them go to 20 to 25. There's some that do 25 air changes an hour. Actually, the renovation that was done at the last hospital that I worked at, they had one that would do 25 air changes an hour. But the regulatory requirement is 20. But they even, architects expect that to increase. They expect it. So they're putting in one that'll do more than the minimum right now. But that's OR. That's in the OR. And the air handler for the OR is most of the time. I can't say always because I don't know. But for the ones that I'm aware of, they are also the air handler for pre and post-op, like all of surgical services. So the capability should be there capability should be there. Now, I'm not an engineer, so,
Mhm.
you know, I'm talking out my ear, but it's the same air handler, and if they can do it in my OR, why can't they do it, 20 feet out in my recovery area?
Right.
God, I don't know.
And Wendy, I'm going to just take a moment here and I'm just going to ask for people to comment. If you know that you get 20 air exchanges or 25 air exchanges, go ahead and just let us know where you work and drop a comments into the show notes, just so that we can get awareness of there are facilities that are out there that are doing it. And then
I would love to know that.
Whether you're a surgery center or a hospital, doesn't matter what size of a hospital, I would love to hear if you have a scavenging system implemented. I don't know of any so far in my region.
Me either.
Before I retire to change that.
And a scavenging system, which I'm sure you covered it before, but for anybody that's just popping in here, it is like an oxygen mask, but it has suction. Okay, so the patient still gets oxygen, but it's suctioned out. So instead of that waste anesthesia gas just being this big plume coming out into your face, it is getting sucked down into this scavenging system and disposed of appropriately. Now, it does eventually go out into the environment.
Mm-hmm.
And by the way, waste anesthesia gas is not excellent for the environment. Okay.
Correct. Yeah.
They're not. I think that it takes like forever for them to metabolize.
Oh, it's years. It's
Years.
I think nitrous is like 114 years that it.
Oh my goodness. See.
And SIVO, I did read it somewhere in all the literature, but it is years, and it does break down the ozone. So, it does impact our greenhouse gases. So
someday there may be a way to chemically alter it, alter it so that it isn't released into the environment, similar to the way cars have a catalytic converter now, so that the hydrocarbons that are released from automotive exhaust go through a catalytic converter, so that what's released into the environment is no longer these hydrocarbons. So if there could be something like that, that hospitals, surgery centers could use, so that it will not release this just in its pure form into the environment. But hey, I'll be happy if we just stop closing the garage with the car running.
That's what we're doing in our PACUs. Yes.
That is
every
exactly
time,
what we're doing.
Like that first round of patients that comes out of the OR somewhere between, 9 a.m. and 10 a.m., and just think of what that concentration in that room is around 10:30,
Yeah.
And then it continues. Like it continues. Like I know we were busy well until like 9 p.m. We would do like 70 surgeries a day. And I know there's hospitals, some hospitals have 100 ORs and they're just massive. So it's a real thing.
Yeah, it's a lot. And so, they talk about long-term exposure as opposed to minimal exposure. And okay, you work in PACU, you've got long-term exposure, unless you're working at 5 a.m. If you're the night shift, maybe you might get away with just minimal exposure. Maybe that's who they're talking about when they say minimal exposure. But because when we were doing those testing, of course they were above the bedside. We had this little alcove that was for the pediatric recovery patients, and that alcove was crazy. There was nowhere you could be in that alcove. And nurses didn't like to be in peds because we just thought it was a hard day. And it was this just nebulous, nobody wants to be back there in that alcove all day. It's just such a long day, but you know what it was? After we realized what the concentration was back there, I mean, you could walk back there and pretty much smell it in the corner. But it was that malaise, that difficulty focusing, that fatigue. It's just such a long day. That was exactly what those white papers say it feels like when you go, this WAG exposure. And by the way, I was just also thinking of one other thing. I was actually thinking of that alcove at the time and those levels that were so high. But what if you had a PACU nurse that had a family history of malignant hyperthermia?
You know,
Of it, but
yeah,
I was like, that's life threatening.
they're triggering.
After, now I don't know what the levels have to be. I would be interested to know. But what level of exposure? Actually, malignant hyperthermia has something called variable penetrance, which means it is dependent on dose and duration. So there are some people that are more sensitive than others. But if you did have somebody with a high sensitivity to those triggering agents, that just means that they are going to have the crisis. They're going to have the signs and symptoms earlier than other people. So it is definitely a possibility. And as somebody who has been a manager before and a director before, it never even occurred to me to ask someone at an interview, do you have a family history of malignant hyperthermia? Of course not. Why would I ask that? They're not having surgery. Oh, but they're going to be around the triggering agent all dang day. They're going to be that. So just the levels of concern is so low. It's almost a non-issue in your day-to-day work. It's not something that we think of. It's not, and it needs to be.
It does.
What an individual nurse can do is really limited. I mean, all I've really seen for an individual nurse is stay 3 feet away from the patient. Are you kidding me? How can I do that? How can I do that?
Yeah, when we need to care for them, it's that time when they're off gassing the most.
Right.
And that's when we need to be
3 feet away is a yardstick.
Yeah, I mean, that's when we're in that breathing zone. And if we're not in the breathing zone, there could be harm to that patient. They could be obstructing and they could become hypoxic.
That's what, that's what I was thinking. Maybe it's not going to be a breathing zone anymore if I'm not in it.
I mean, if we stay out of the breathing zone, then they won't breathe. Then you're protected. But then you're also in for a way more bigger trouble. So we have to figure out a way to get the awareness out there, get hospitals realizing that this is a serious occupational hazard. I remember when I first learned about WAG, when I started in PACU in 2016, never heard of it. No one ever, had zero education about it, did not know anything. And then in 2021, I did a webinar through ASPAN, and they were talking about WAG, and I was like, what is this WAG? And I had no idea, and I was so shocked, like jaw dropped, like what? Why has no one ever said anything about this? Why have I had no education on this? And so I was so moved that I reached out to Dr. McLaughlin, who did a lot of the research. And I have a video, and if anyone's interested, please go listen to the video, because he has done extensive research on it, and with NIOSH specifically, and it's profound, the data. And so that was just the beginning, let alone did I know that I had an inflammatory thing going on in my body. And a year later, I'm going to have a 6-hour robotic surgery to get all that adhesions and scar tissue out of my body. And then now I think COVID really slowed down the movement of WAG with our regulatory agencies. And I'm glad to see the re-awareness has returned. And I hope that the momentum does not stop. And I hope that this, in the next few years, or well, hopefully in the next months, that hospitals will realize that this is something that they need to be implementing a scavenging system to protect their staff. Because you're right, we have to be in that breathing zone, in that immediate emergence period. There's no option about it. We have to care for the patients, but we also need to be protected as we recover. I mean, like you said, and you're in the PACU, in a 12-hour shift, depending on the turnaround, you could have something crazy like 12 patients a day. It's more like 8 to, somewhere around there. But still, think of that 8 different times you're going to get dosed. And if you can taste it and smell it 125 times above the recommended exposure limits, I mean, that is phenomenal and profound, the impact. And I don't want a bunch of nurses leaving PACU. We need our nurses. So you
got to treat them right.
We got to treat them right.
There are dosimeters that you can wear that'll measure parts per million, but it only measures for a few of the gases. And I know isoflurane, halothane, maybe enflurane, but it's all old stuff. It's stuff that isn't really used anymore. And a lot of the studies are also on older halogenated gases. Now, we still use nitrous oxide regularly. We still use sevoflurane regularly. And those two are on some of the studies, but those dosimeters you can wear, something like that would be a chew. There's a type of sterilizer called ethylene oxide that is being phased out because it's also very dangerous to people and to the environment. And it's actually a federal law. It will be banned in 2030. So it's being phased out for a lot of the same reasons. Now, it's possible to phase out a type of sterilization. It's impossible to phase out anesthesia gases. We don't have another option really for the surgeries that we do. But they do have like this little litmus paper looking thing that'll clip onto their collar, so that if they exceed the parts per million, it turns dark, and then they must leave the area. They've reached their parts per million for the day, they must leave the area. And something like that would be helpful. But can you imagine being the charge nurse that day and half your staff's badges turned dark? What are you going to do? Probably nothing.
Well, and so to come back to the scavenging systems, when they implement scavenging systems, the staff don't have the symptoms of those that are exposed to the gas. So another cry for, we need to implement scavenging systems.
And it would also remove airborne particles. So like COVID or TB, so it reduces your exposure, not just for waste anesthesia gases, but for any of those respiratory isolation kind of things.
Yeah. Yep. All your pathogens like RSV or influenza, COVID.
Yeah.
Yeah. I mean,
call offs.
And I know I would love that. I can't tell you how many times we're like, say cough, and it's just, whoosh, I mean, and you're like this.
Yeah. Thanks,
you're like,
job.
So, I mean, it's a win-win all the way around with these scavenging systems to control WAG and pathogens. I mean, for me, if I was the director or the manager, it'd be a no-brainer. We have to figure out a way to retrofit our PACUs, our recovery areas, and even like if the patient's going to ICU, we need to protect those ICU nurses, because there's several ICU patients a day that are getting recovered in the ICU. Now they usually have multiple suction setups, so it should be easy to implement a scavenging system in the ICU. I know IR, we would go to PACU with our anesthesia cases. But one area in IR that I hadn't thought of that we used nitrous all the time was for our VUGs, for our kiddos. And we didn't have a scavenging system in there. So there's many areas, GI lab, although they usually use TIVA, but sometimes they'll go to a MAC. And so
CBICU was the first place I was probably ever exposed, because I worked in a CBICU before I went to surgery, and we recovered all the hearts. I mean, they didn't go to PACU, they go straight to the ICU.
Right.
So there are some ICUs that do receive patients, straight from the OR. And so I know those nurses don't even know about waste anesthesia gas at all. Because I certainly didn't. I had no idea it was a thing.
Yeah, me too. And you know, it's something, yeah, it's definitely something that we need to bring awareness to. So let me just go ahead and I will drop this in for images, but this is the NIH occupational exposure levels. And it does have on here for sevoflurane, which is probably the most common halogenated gas that we use in general anesthesia, at 2 parts per million. And they updated this as of December 2022. So I'm going to put a bunch of references in the show notes for nurses to find the ASPAN white paper and their new position statement on waste of anesthesia gas outside the operating rooms. And then I'll also include research done by DOHS under NIH. And then also, this is something that is pretty old from CDC. It tells you how long they've known about WAG. And it's a shame that we haven't implemented protection for our employees against this occupational hazard. But I'm going to go ahead and just read off some of it. And as I read it off, I'll drop it in so that when they see it, they'll see it.
And I think it's in that DOSH paper that has, when it's mixed with nitrous oxide, the limit is actually 0.5 with nitrous.
I'll try to find that and then take a clip of it so that we can drop it in too. All right.
My eyeballs fell out when I read that.
I know. Well, all of this is jaw-dropping information. I mean, it really is. So I think what I'm going to do is just share the screen here. So this is the CDC Occupational Hazard in Hospitals statement on WAG. It's shared public information and it's allowed to be reproduced and shared in any manner. So this is the contents, the table of contents, an introduction about what is waste of anesthesia gases, what are the health effects of exposure to waste of anesthesia gases, workers likely to be exposed of the gases, and how employers can reduce worker exposure to WAG. So who is exposed to waste of anesthesia gases? These are all the hospital workers who may be exposed. So of course, the anesthesia team and our CRNAs, the dentists, nurse anesthetists, operating room nurses, OR room techs, other personnel in the OR room, as you talked about, Wendy, recovery room nurses, other recovery room personnel. So you know, the ICU nurses recovering post-op patients.
Patient care techs.
Yeah, patient care techs, transport, respiratory therapy. So how can employers reduce the workers' exposure to WAG? So first, they need to establish a hazard communication program and then implement that program. That includes information about the hazard and methods to control it. And there's a whole process that goes on in the OR, Wendy, with the anesthesia circuits. And we're not going to really focus in on that right now because we're really focusing on the PACU nurses. But we need to train our nurses because the OR team, they know about it. And every OR does have a program and a scavenging system for WAG. Really, the knowledge deficit, the education gap is really in our PACUs. So we need to train our workers. And right now, OSHA doesn't have a recommendation for WAG and PACU. And so I really would love to see OSHA make a movement on that and get on board with some recommendations.
As well as ASPAN making it a recommendation. And I mean, a position statement is definitely a step in the right direction. I love it, but I want to see it as a recommendation so that Joint Commission and other regulatory bodies will be looking for it as well.
Wise words, Wendy. And then they recommend for the employers to protect their workers to install a scavenging system to remove the WAG from the operating rooms, place an exhaust in the area where the waste gas will not be reintroduced into the intake air for the facility. So that's what they say currently. We just saw what the CDC recommends for the operating room. They don't have recommendations for the PACU. So there's a deficit there. We need OSHA and the CDC to make recommendations for WAG control for the occupational hazard in the PACU.
And the patient is the source.
And the patient is the source, absolutely. So they do recommend to train all the workers on hazard awareness, prevention, and control of exposure of waste anesthesia gases. Develop a program, and then they also want you to repeatedly measure, which we talked about, Wendy, of the WAG in the breathing zones of the most heavily exposed workers while they perform their usual procedures. So that could be implied, the PACU, because those nurses,
I think so.
Are working in that breathing zone. Okay, and the PACU just has been omitted from this, but they are a part of the care of that patient's breathing zone. Employers should keep records of air collection samples for 30 years, and then also keep medical records of workers' exposure for 30 years after their employment has ended. And so I found that quite profound. And ASPAN did add that to their position statement. Again, it is to track the employee's health. So now I want to just share with everyone what OSHA does say about WAG. OSHA says that waste anesthesia gases such as nitrous oxide, halothane, NO-fluorine, also SIVO, isoflurane, waste gases results from poor work practices during anesthetization of patients, improper or inadequate maintenance of the machine, and or patient exhaling after the surgical procedure in the recovery room. So there we have it. OSHA is saying that it is exhaled after surgery when they are emerging in the recovery area. So this is what OSHA says about the health effects of exposure to WAG. Can cause drowsiness, irritability, depression, headaches, nausea, problems with coordination and judgment, chronic exposure, embryotoxicity, miscarriages, liver and kidney disease, and cancer. So really, really heavy consequences for not implementing protection for our staff.
And if you think that you don't have chronic exposure and you work in a recovery area, you're wrong. You have chronic exposure because that's every day. It's every day.
Yeah. Well, Wendy, I really appreciate your time taking out of your busy day to just talk about WAG and the importance of bringing this awareness to the nurses at the bedside. You have a wealth of knowledge from the operating room. If people don't know about Wendy, she is the owner of Zander Perioperative, and she helps nurses pass the national certification for a CNOR. And so thank you so much for partnering with me and just having a discussion about WAG and just promoting awareness and protection for our staff.
I'm a big geek about it, you know, and I always enjoy talking to you, and because I found somebody who's just as passionate as I am about the people at the bedside and caring for patients and having good outcomes, not just for our patients, but for the caregivers too. You know, I want good outcomes for them and for them to live their best life. And when they're struggling with problems in their DNA synthesis and protein and ATP and all of the things, that's everything. That's all of your body processes. And I want their families to be healthy and their reproductive health to be healthy. So I think it's something that we need to talk a lot more about. And I hope that there's more regulatory requirements around it. And I feel like 18-year-old me or maybe 24-year-old me new in the field would just hate me saying that. But I know that real change at the bedside happens because there are consequences if you don't do it from a facility. So you need to have those consequences. So talk to the people who matter. Let your voice be heard. And do add comments. I want to know what her. I'm going to come back and look at the comments here, and I hope that we see that there are some people that are doing this in their own facility. I hope there are some, because my experience and Kathy's experience in our own area is it's not here. So we know that it's a possibility. It's just not our practice. So is it your practice? Is it out there somewhere? Gosh, I hope so.
Yes.
Do you need a verse?
Yes, everyone, please drop a bunch of comments into the show notes. Let's start our own discussion right here on YouTube. Let's get our minds thinking. And yeah, I will also leave contact info for Wendy and contact info for me. We will give you all the literature that we reviewed before we did this video discussion. Definitely take it back to your champions at your hospital. And it should be a multidisciplinary approach between surgical, anesthesia, nursing, and then engineering needs to be included in on it. And as you dig through all of the literature that we'll share, they talk about if you don't have a WAG program, you'll be able to figure out a way to implement a WAG program by reading all of this literature. So thank you so much, Wendy.
Good luck.
Please subscribe to the channel if you've been enjoying it for these past few years. It really helps to keep the channel going. And do you know that 30% of my viewers are subscribed? That means 70% of you watch and you're not even subscribed. So go ahead and help this channel out and subscribe, please. All right. And share and like and ring the bell.